So for this case, we have a 73-year-old female with a history of coronary artery disease, biventricular systolic heart failure requiring implantable cardiac defibrillator, paroxysmal AFib, treated with amiodarone for 2 years, who presented with abdominal pain, nausea, loss of appetite, and fatigue for 1 month. She also reported a recent ICD discharge. Initial vital signs were remarkable for a blood pressure of 215/91. On exam, she appeared comfortable and in no acute distress. She had a non-tender thyroid without enlargement or nodules, and no proptosis. Her abdominal exam was just notable for some mild diffuse tenderness. Her EKG showed no acute changes. ICD interrogation revealed 1 episode of ventricular tachycardia and multiple episodes of AFib with RBR. Lab evaluation revealed an elevated troponin at 0.342, undetectable TSH, an elevated free T4 of 3, and total T3 of 79. TPO and TSI antibodies were negative. Thyroid ultrasound showed normal size and echogenicity with few scattered and cystic nodules. There was mildly reduced heterogeneous tracer uptake on technetium scan, consistent with thyroiditis. The clinical presentation and labs were consistent with AIT, or amiodarone-induced thyrotoxicosis. She was initiated on prednisone, methimazole, and cholestyramine in addition to her beta blocker. Despite maximal medical therapy, her free T4 continued to uptrend, peaking at greater than 5.2. She underwent plasmapheresis as a bridge to thyroidectomy. After surgery, her free T4 normalized, abdominal symptoms resolved, and she had a lot more energy. Her final surgical pathology revealed follicular epithelial degeneration, phomohistiocytes, and mild lymphocytic inflammation, consistent with AIT. AIT is due to disruption of thyroid hormone synthesis or direct damage to thyroid cells. It's a life-threatening disorder that can present with cardiac arrhythmias or heart failure exacerbation. The prevalence ranges from 2 to 10%, with fewer cases in iodine-sufficient areas such as the United States. Diagnosis is made when TSH is suppressed and free T3 and free T4 are increased. There are 2 types. Type 1 is due to increased synthesis of thyroid hormone and is treated with thionamides or radioablation. Type 2 is caused by increased hormone release from destructive thyroiditis and response to glucocorticoids. By definition, AIT1 is associated with the presence of thyroid nodules or a diffuse goiter. However, this can also be present in AIT2. Overall, most evidence shows that standard thyroid ultrasound has low diagnostic value in distinguishing between these 2. Technetium scan in small studies has been found to be helpful in distinguishing between the 2, with normal or increased uptake in patients with type 1 and absent uptake in patients with type 2. If you'll recall, our patient had mildly reduced uptake, making her type unclear. When the type is unclear, patients are treated with both steroids and thionamides. AIT can occur at almost any time during amiodarone therapy. Signs and symptoms range from asymptomatic presentation discovered on routine labs to typical hyperthyroid symptoms such as palpitations and heat intolerance. Classic symptoms of thyrotoxicosis can be absent due to the antiadrenergic action of amiodarone and its impairment of conversion of T4 to T3. Besides the arrhythmia, this patient's symptoms of lethargy, fatigue, and malaise were unusual. But this case highlights the apathetic hyperthyroidism that can sometimes be seen in the elderly. In cases that do not respond to medical therapy such as this, surgery is indicated. Plasmapheresis can remove cytokines, antibodies, and thyroid hormones. However, it is only a temporizing measure until surgery. There's no immediate benefit to discontinuing amiodarone given the long half-life. In conclusion, some of the takeaway points from this case was that the primary physician's role of taking a comprehensive medical history, including MedRec, is of utmost importance. It can be difficult to tease out whether a certain drug is causing your patient's presenting symptoms, but it's important to keep medication side effects on the differential. In addition, this case reminds us that our elderly patients with hyperthyroidism can sometimes present atypically. Thank you.